Bioethics 2.0, Podcast Episode 8, Disclosure, Truth-Telling, and Communication. Bioethics 2.0 Podcast, Episode Guide. This is Podcast Episode 8. The topic is Disclosure, Truth-Telling, and Communication. You can find this information in Introduction to Clinical Ethics by Fletcher, Chapter 8. Additionally, this information can be found in Schroeder's Practical Ethics for Nurses, Nursing Students, a Short Reference Manual, Chapter 7, also known as the Green Book due to its green cover. A typical scenario.
A patient comes to a clinician, and the patient has a problem. Then the clinician evaluates, diagnoses, and tries to resolve that problem. This calls for collaboration that is characterized by mutual acceptance, trust, and respect. That is the ideal of the clinician-patient relationship. The goal of the interaction is to develop a plan of care with the patient or the surrogate as a full partner. And the plan should be systematic and continuous. It should be constantly reevaluated and adjusted in light of new medical information, changes in the patient's condition, and the contextual framework of the situation. The take-home message of all of this is, of course, no part of any of these activities can be accomplished without effective communication among all parties involved. Some common questions.
There are a variety of common questions that arise when it comes to communication. Some include, what should the patient be told? What should the family be told? Who should be told first? Who should inform the patient? When should that happen? How should that happen? Where should that happen? Can the truth be disclosed without destroying hope? And is lying ever ethically justifiable, especially to protect the patient from harm? Some general attitudes among healthcare professionals.
In order to answer some of those questions that we asked, it's interesting to take a look at the prevalence of general attitudes among healthcare professionals. This is a summary of some of the literature on the topic. In one study, a majority of clinicians indicated a willingness to misrepresent a diagnostic test to secure an insurance payment. In another, a majority of clinicians surveyed would mislead the wife of a gonorrhea patient to ensure that she gets treatment, with the goal to preserve the marriage. Another study suggested the 1/3 would offer incomplete or misleading information to a patient's family if a mistake led to a patient's death. All of these data are very interesting and point to the barriers and failures of communication. The ideal relationship.
Features of the ideal clinician-patient relationship feature the following: choice, competence, compassion, continuity, lack of a conflict of interest, and communication. Knowing, of course, that communication is a two-way street. What is good communication?
It involves listening and understanding the patient and what values they have. The clinician should also know the effects of the disease on the patient's life, their family, their job, and their other life goals and pursuits. And when that communication is good, patients are less likely to misinterpret the information they receive, more willing to ask for clarification when information is unclear, and quicker to call if symptoms fail to resolve.
Language and communication.
The clinician's word can have impact at many different levels. For instance, imagine giving a diagnosis of cancer. Those words can even affect healing in the body itself. So how attentive you are as a listener is very important. One of the things I try to teach my health profession students is that if they try to model good communication, if they can do one thing, it should be to change at the end of the conversation when clinicians usually ask, "Do you have any questions?" And of course the usual answer is no. You are giving the patient the opportunity to say no, I don't have any questions. And what I would like to see is open-ended questions in that communication style. Rather than asking, "Do you have any questions?" you should ask, "What questions do you have?" If I could change one thing about communication styles for clinicians, that's what it would be. It provides the opportunity for a patient to ask questions. It's likely that patients, in fact, have those questions, and they want to be prompted. They want to have you give them permission that it's okay to ask those questions. And using this open-ended style of communication can help in that regard.
Clinicians should know how their spoken word can have a great impact. Since it's better to show than to tell, we have uploaded a tongue-in-cheek example to illustrate the point.
I should feel given him a mild sedative, so I could be able to go on tomorrow.
Daddy's gonna be so excited.
That killed him.
Paging Dr. Palmer, Dr. Barbara Palmer, dial 452.
How do clinicians fare?
Physicians don't fare very well when it comes to communication. Communication is often inadequate. Patients say they are not satisfied with the interactions, especially among physicians. There are a variety of reasons to account for this. Obviously, physicians don't have a lot of time to spend with patients anymore due to some time constraints and things like pay for performance. Sometimes patients cite other factors, such as lack of warmth and friendliness. Failure to consider patients' concerns and expectations is another thing. Obviously, the use of unfamiliar medical jargon can complicate things. And the lack of adequate explanations concerning diagnosis and cause of illness that the clinician is trying to provide to their patients is another factor. All of these things can be overcome through good communication. As a side note, nurses rank more highly than their physician colleagues. Nevertheless, there is always room for improvement when it comes to a communication.
Barriers to communication.
Knowing the barriers to communication is certainly one way to help expand communication and improve it. Here are some of the barriers. A lack of educational curricula and training in interpersonal skills in humanistic care. That can certainly be a barrier to clinicians having the right techniques and skills to understand how to communicate. This, of course, is changing, and there are changes occurring both at medical and nursing education to help improve this situation. Another barrier is the overemphasis on specialization and technical expertise. Another is the tendency for clinicians to feel the need to focus quickly on the patient's problem. Research has shown that a patient generally has 10 or 20 seconds or even less to tell their story before they get interrupted and put on the track of the subjective-objective assessment and plan. Another barrier is that communication among providers is not encouraged or fostered. Some clinicians or physicians still see their role as very paternalistic, so they themselves can create yet another barrier. They don't communicate with their patients well. And of course, different professions have different information, different focuses, and different styles of communication. The upshot of all of this is that many of the ethical dilemmas that we frequently see in the clinical setting that lead to ethics consultations may usually be problems resulting from the lack of communication.